95% of those with subclinical hypothyroidism did not develop overt hypothyroidism. This is great news. Hey everyone, welcome back. Today, let's discuss a number of research studies in the area of thyroid that can inform our opinion and help us with the fact that 37 to 61% of you watching this might be on thyroid hormone that you don't need. And also that there are simple things that can be done to improve thyroid autoimmunity and help you better understand that thyroid autoimmunity, although something we want to be concerned with, is actually not nearly as common as it's often portrayed. And why this matters is it frees you up from not having to be worried. We want you to be empowered. And if you need a hormone, sure. But if you don't, let's not fall into the mistake of just going on it because it was theorized that you should. And again, we'll look at data. We want to use research to inform our opinion and not subject you to theory or to speculation. So we'll cover a number of research studies as our list here depicts. A few of these are in the area known as subclinical hypothyroidism. This is where there's a mild elevation of TSH. And we'll detail the evidence, but in short, data are clear that people with a TSH of 4.8, of 5.3, of 6.1 don't seem to benefit from thyroid hormone. So we'll detail that data. There are also some concerns with the use of T3 hormone. Not to say you can't or you shouldn't, but it's kind of dispensed like Pez, dispensed like Pez in the field of functional medicine. And for some, it is helpful. However, there are risks that may accompany this, and we'll cover a study that I feel you should be aware of in that realm also. We'll also talk about certain toxins and how these can have a minimal but notable impact on your thyroid gland and simple steps you can do to avoid these toxins. And then we'll pivot over to Hashimoto's and what are some nutrients that can reduce this thyroid autoimmunity. So we'll start off again with subclinical and overt hypothyroidism studies. I want to lead just with some context here because oftentimes people are confused. So you need guidelines. You need guidelines for what's normal thyroid, what's subclinical, meaning there's some abnormalities, but nothing to the point to where it's a problem. And then there's overt hypothyroid. There's also sluggish thyroid, and sluggish thyroid, said simply, is really not a thing. It's an early hypothesis, and certainly not everyone agrees with me here, but my opinions are a derivative of the evidence, and I should say the good evidence, not theory based upon mechanism, what should happen, but show me the hard clinical science. We give people a treatment, they get better or they don't. Bottom line, that's what I want to see. That's what I want for you. I don't want you to be subjected to the theories. So sluggish thyroid, when your TSH is in the normal range, conventional normal, this is one area in terms of the thyroid values that conventional medicine has right. And I can understand if you've seen an endocrinologist and it's been a bit lackluster, okay, but that doesn't mean you write off the entire field of conventional endocrinology just because maybe your endo had poor bedside manner. So normal thyroid function is a TSH that's usually between, the cutoffs vary slightly from lab to lab, but 0.5 to 4.5 or 5. And T4 is 0.8 to 1.8. Now, subclinical hypothyroidism and studying this is really where we can learn quite a bit. Subclinical hypothyroidism, and I'll show you a few additional studies today that document these individuals do not benefit from thyroid hormone replacement therapy. But how do we define it? This is where your TSH is high. It's flagged high by LabCorp, by Quest, wherever. It's above 4.5. It could be 5, 6, 7, 8, 9. Usually when you get above 10, then it's considered hypothyroid. So what this means is for people who have subclinical elevations of their TSH, 5, 6, 7, they do not benefit from thyroid hormone. But wait a second. My doctor told me that my TSH of 4.1 was sluggish and therefore I need hormone. Well, guess what? People who have even more sluggishness in their thyroid have been studied, and we've clearly documented they don't improve. And we'll cover the data here in a moment, but just want to give you this framing. And then hypothyroid is when you see the TSH usually above 10, and where exactly we draw that line varies from study to study, but it's roughly 10, paired with a conventional lab range, low free T4 below 0.8. But as you're probably accustomed to me saying, show me the evidence. Okay, study 1, a review paper from 2022. They found that treating subclinical hypothyroidism with levothyroxine does not improve fatigue, depression, quality of life, or weight. Remember, this is in a cohort who have elevated TSH, 4.9, 5.3, 6.3, whatever it is, and they don't get any better. Now, it's quite important to consider the placebo effect. I'm not feeling well. I want to feel better. What can I do to feel better? Oh, here's this promise of thyroid hormone being able to help me, likely introduced by a clinician who's well-intentioned and truly wants to help. And then what do you know? With the expectation of the patient and the doctor of the thyroid hormone being helpful, when the person reports back a month or two later, they say, yeah, I'm feeling better. I always want to honor how someone feels. However, it's crucially important to juxtapose that non-controlled placebo-laden trial, N of 1, with what happens when we look at controlled settings, meaning half of the people will be given thyroid hormone. The other half will be given what they think is thyroid hormone, but it's actually a sugar pill. Now we can see, is there significantly more benefit in the group getting the hormone as compared to the sugar pill? And guess what? No, there's not. You can look at this different ways. You can get defensive and say, oh, well, I know it's my thyroid. Okay, listen, I'm on your side, right? But what I don't want is for you to go on what's typically lifelong thyroid hormone therapy if you don't need it. And this is where we look to data to help us see if you have been plagued, and I'm sorry if you are, it stinks to feel fatigue, depression, having a generally low quality of life, or weight gain. We don't want those things for anybody, of course. But we don't want to give you a false or a spurious solution. So there's one evidence point. Now, you may have heard me say in the past that there are a couple subgroups that appear to benefit from thyroid hormone replacement therapy who are subclinical hypothyroid. One of them is pregnant women. As I've been following the data, and my opinion is always a reflection of the data, that's been my response. That's been my recommendation. This meta-analysis of 9 randomized controlled trials in over 11,000 women did not find that giving subclinical hypothyroid pregnant women improved pregnancy outcomes, preterm delivery, miscarriage, gestational diabetes, or preeclampsia. So I'm now revising my opinion on this, and I would ultimately, of course, leave this up to your endo or your OB, but as the literature is evolving, it appeared pregnancy outcomes may be improved from thyroid hormone. And if that's the case, my goodness, yes, right? I think no opposition there by anybody. However, as more and more data comes in, we have a more accurate read. And this meta-analysis gives us probably the most accurate read, which seems to inform that thyroid hormone is not going to be helpful in improving pregnancy outcomes. Okay, and now this next study wanted to look at if you do have subclinical hypothyroidism, a TSH that's mildly elevated, 5, 6, 7, 8, 9. What do? Do you get worried? Does this mean you're on your way to hypothyroidism? And as I've said so many times before, again, as a reflection of the evidence, most of these cases, most of this mild elevation of TSH will normalize all on its own. Here is one more data point finding that same thing. Observational study, so it's not super high quality, it's not controlled, but they're watching people over time, 412 people in this case. And what they found after a 3-year follow-up, 46% became euthyroid, normal thyroid. Yay, 46%. 45% remained subclinical. So you had this TSH that hovered around 5, 6, 7, didn't get any better, didn't get any worse. And only 4.6% became overtly hypothyroid. Said another way, 95% of those with subclinical hypothyroidism did not develop overt hypothyroidism. This is great news. This means you don't have to freak out about having a TSH of 5, 6, 7. Combine that with the fact, like we just covered from the other review paper, that those with a TSH of 5, 6, 7, 8 don't benefit from thyroid hormone. Hopefully now you have a better appreciation of why I've been so critical of the functional medicine sluggish lab range values. It's well-intentioned, and I don't doubt it comes from a good place. But with more research, with more science coming in, we are now seeing that that well-intentioned hypothesis, albeit it may be, doesn't produce benefit. And oh, by the way, these people who had this elevation of TSH, if we didn't do anything, they would go back to normal and wouldn't need lifelong thyroid hormone medication. Okay, moving along to another review paper. And their conclusion really says it all, or one of their quotes, and I'll read the quote here for you. Prior to confirming a diagnosis of subclinical hypothyroid, serum free T4 and TSH levels should be reassessed 1 to 3 months later in order to rule out a transient increase in serum TSH levels. This is so well identified that review papers are recommending, hey, wait a minute, don't go right on thyroid hormone if your TSH is 5, 6, 7, 8. Again, always check in with your doctor, but you have the prerogative here for a second opinion. What they're finding is most of these, 95%, will not become overtly hypothyroid. If we combine that again with the fact that people with this subclinical hypothyroidism don't benefit symptomatically, and as we've discussed in other podcasts, the meta-analysis that found 37% of people were on hormone that didn't need to be, now we start seeing why. Because when Jane, hypothetical Jane here, went in and her endo or whomever wanted to help, and Jane was maybe tired and depressed, and her TSH came back as 5.1, and the conclusion was, well, why don't we put you on thyroid hormone? Well-intentioned, but these people will then be on that forever unless they double check. And now we see that 37% of the population, as much as 61, according to another study, of people have been given thyroid hormone that they don't actually need, and it doesn't help their symptoms. So you want to bear this in mind, because you don't want to go on lifelong medication if you don't need it. And more than anything, I want for you to feel better, but we don't want to use something that looks like it might help, but actually does not. Now, this next study, I actually kind of disagree with part of what this study is saying. I think it's the endocrinology community being a bit myopic, for lack of a more tactful term, essentially criticizing that 40% of doctors will recommend T3 for patients with persistent symptoms. So even though they're on T4 and their TSH and T4 are normalized on, let's say, levothyroxine, but they still have symptoms. So 40% of endocrinologists are willing to entertain also adding in T3. And what they're saying in this conclusion or this quote is because there's inconsistent evidence that T3 is helpful. And inconsistent is kind of a vague term. There are some meta-analysis data that have found 45-ish% of individuals will report that they feel better when they use T3 along with T4. And this was something I was skeptical on a number of years ago. As more and more data have come in, I've kind of softened my position given some of this information. However, there's one other thing I want to tie in, and this is that T3 is not without risks. This observational study of over 5,000 people, they found that in those who are on T3, there was a 1.6 times increased risk of heart failure and a 1.7 times increased risk of stroke. So this is something to really keep in mind, and the risks were greater in those who were on it for over 1 year. This is not a huge elevation, right? 1.6 is just a 0.6 above baseline risk, or 0.7. But it does give me pause in that, okay, we want to make a case that someone needs the hormone, and most importantly, we want to be very confident that when they went on that hormone, they experienced a symptomatic benefit. So what we've published on is this very clear observation that when people have those persistent symptoms, those symptoms may not be coming from thyroid. They might be coming from the gut. We know that the symptoms of hypothyroidism and the symptoms of gastrointestinal dysfunction are quite similar. Constipation, thinning hair, dry skin, depression, anxiety, brain fog, fatigue. So what we've documented in a 6-part case series is that we were able to see very high levels of symptomatic improvement when focusing on gastrointestinal health instead of adding T3. What I think happens here, and this is partially me speculating, but at least the physiology here supports what I'm about to say. There's 2 ways that you can optimize your T3. One is take T3. Okay, that's an option. I think it's a option to consider secondary to improving your diet, your lifestyle, and your gut health. We know that people who are inflamed, overstressed, underfed, and have gastrointestinal symptoms or inflammation have a thwarted ability to convert T4 to T3. So perhaps the best way to come at this is to improve your endogenous ability to convert T4 to T3. Allow your body to do it on its own, optimize that rather than just giving T3. I still think you can make a case for when someone's on T4, they've improved their gut health and their diet and lifestyle, and they still have symptoms, then T3. But I feel it's best to reserve it to that point in time. Now, coming back to subclinical hypothyroidism, this study did find that those with subclinical hypothyroidism had a risk of elevated lipids. So this is something to note, but it doesn't seem justifiable to use thyroid hormone to lower elevated lipids because there are so many other things that can lower lipids. Combine that with the fact, again, we're seeing this come up in another study, that in 45% of individuals, their TSH normalized with time. So again, what we don't want to do is be too quick to say, well, your TSH is 6, go on hormone, rest of your life. Like the other paper concluded, retest TSH and free T4 within 1 to 3 months because there's a good chance you'll go back to normal if you do nothing else. We'll also cover a study here that can enhance your normalization likelihood, but even if you did nothing, the odds are in your favor that your TSH will normalize. And this is the toxin study I alluded to a moment ago. This observational study, albeit small, 126 patients, so it's observational and it's not controlled and it's small, but they assessed urinary phthalates. Phthalates are plasticizers found in shampoos, soaps, hairsprays, lotions, deodorants, plastic containers. And those with high urinary phthalates had a 76% increased risk of subclinical hypothyroidism. But remember, subclinical hypothyroidism is transient in the vast majority of cases and does not benefit from hormone treatment. However, you could go to Environmental Working Group's website and start looking at some of the self-care products you're using and just weeding out those that are high in phthalates. And that would be a simple exercise. Be reasonable. I don't want you to have this feel of, oh my God, anything with phthalates, I've got to weed out. Go after low-hanging fruit and leave it there. Okay, coming over to Hashimoto's and Graves'. These are some of the natural and dietary interventions you can use to improve your prognosis if you do have Hashimoto's. Those who had a higher dietary selenium intake had a 35% reduced risk of Hashimoto's, and they had lower TPO antibodies. Reminder, some of your top sources: Brazil nuts, fish like tuna, halibut, sardines, meat, beef, turkey, chicken, and liver. Now, I also wanted to share this study because depending on how you interpret it, you can perhaps become amenable to dietary fear, and I want to try to preempt this. Observational study, 623 individuals with celiac disease. Now, compared to healthy adults, those with celiac had a 2 times increased prevalence of thyroid disease and autoimmune thyroid disease. Now, I want to call your attention to some of these specific prevalence data. Firstly, this is thyroid disease in general, which includes autoimmune, non-autoimmune, goiter, hyperthyroidism, Graves', those who had thyroidectomy. So this is essentially everything. It's not hypothyroid, which is really important to delineate because as you're seeing here, the prevalence of thyroid disease, 26% in those who had celiac, and it was less in controls, healthy controls, 13%. If you remember back, hopefully you do, I've shared with you that the prevalence of overt hypothyroidism is 0.3%. Now, it's important to disclose that, well, this is a lot higher, 26 and 13, and this is because overt hypothyroidism is 0.3%. All thyroid disease is anywhere from 13 to 26%. The other thing that I think is important to look at here is the prevalence of thyroid autoimmunity. You've probably heard that everyone with Hashimoto's should avoid gluten. That doesn't seem to be the case. There's certainly an increased prevalence, but look at this. In those with celiac, 15% had Hashimoto's, and in the control healthy population, it was 7.5%. The reason I mention this is, A, to help you understand that Hashimoto's is not perhaps as common as it's thought to be, and there is a doubling of risk of celiac associated with Hashimoto's, but it's not coming up on 70% of people, let's say, with celiac have Hashimoto's, or of those with Hashimoto's should be avoiding gluten. And I'm partially drawing an inference here, but the inference I want to draw for you is just to prevent what we see in the clinic so often is people who develop this really perverse relationship with food because they're not given prevalence data. They hear that people with Hashimoto's should avoid gluten, and they think sacrosanct, everyone avoid it, no questions asked. Doesn't matter if I've had gluten a few times and I feel okay. Now, if you've had gluten and you clearly notice an aversion, that's totally fine. However, nocebo effect, negative expectation, can lead you to think you had a problem when you didn't. Why all this matters, zooming way out, is psychosocial flexibility. You want to be able to maybe have a beer. I'm not saying you have a beer every day, but on occasion, have a slice of pizza. Or have healthy grains that are containing of gluten. And not just conflate everyone into the bucket of celiac, which is about, I believe, 1% of the population, or non-celiac gluten sensitive, which is greater than celiac, but still is between 0.3 and 10% of the population. So no matter how we slice it, yes, on the one hand, gluten can be a problem, but no, it's not a problem for everyone. And it's important we start having this conversation so that people don't avoid gluten based upon faith or fear alone, and go through this simple exercise. Avoid it for about a month, reintroduce it, Do you notice symptoms? Do you do it a couple times and notice those symptoms are clearly reproducible? And if you do, avoid gluten. And if you don't have to avoid it because everyone else is, or based upon, again, faith or fear. Now, one other thing I want to bring your attention to is oral lichen planus. This is essentially when you have sores in your mouth and on your tongue. In those who have Hashimoto's, there's also an increased prevalence of this oral lichen planus, about 40%. And we've discussed this on the podcast before. Additionally, in those with the oral lichen planus, about 27% have autoimmunity against their parietal cells. And this can put you at risk for B12 insufficiency and also for low levels of hydrochloric acid. And there have been 2 studies coming from Japan that have found that B12 injections were actually able to normalize these antiparietal cell antibodies. So it's just something to be aware of. If you have Hashimoto's and you have these sores, you might want to consider HCl supplementation as a trial. And if it helps, keep going. And if it doesn't, I would stop. Again, check in with your doctor on this. And you may, and this is a really early finding only in 2 studies, but you may be able to arrest that parietal cell antiparietal cell autoimmunity, with B12 injections. And further good news as it pertains to Hashimoto's, and this same thing actually also applies to subclinical hypothyroidism. Patients with Hashimoto's in this clinical trial of 62 individuals were given myo-inositol at 2 grams per day, vitamin D at 4,000 IUs per day, or a combination of the 2. And they found the combination of vitamin D and myo-inositol led to the greatest reduction in TPO and thyroglobulin antibodies, as well as TSH levels. So with dietary intake of selenium, with myo-inositol, vitamin D, and also supplemental selenium, you can improve subclinical hypothyroidism, and you can also improve your Hashimoto's. And here's one similar but different study, randomized control trial, 42 patients with Graves', so the autoimmunity that underlies hyperthyroidism. And the intervention was methimazole, which is a anti-iodine drug which can correct hyperthyroidism, or methimazole plus vitamin D and selenium. And what they found was a combination of vitamin D and selenium along with methimazole led to improvements in free T4 and quality of life. However, I want to just disclose that the reduction difference in T4 wasn't huge between groups. The methimazole led to a 2.2 point reduction in free T4, and the addition of selenium and vitamin D led to a 3.7 point reduction in T4. There was a 1.5 difference between groups. So it's something, and certainly I think it's worthwhile to use, but I wouldn't say it was a large enhancement effect from the selenium and the vitamin D. Again, worth a shot. And a lot of this we have organized into our thyroid course. I just want to make you aware of this if you are floundering and you've heard all these different opinions and you're not really sure what to do, how to eat, how to supplement, how to interpret your lab work. So I'll just direct you to our thyroid course if you need some help with how to navigate this. And I totally can appreciate how confusing it can be. Okay, so lessons learned. What have we learned from these research studies? Well, firstly, that subclinical hypothyroidism usually does not require treatment. It will remit or normalize all on its own in most cases. And selenium and myo-inositol can improve that normalization rate. The use of T3 hormone is not without risks. Toxins, phthalates specifically, you can take reasonable steps to reduce your phthalate exposure. And regarding Hashimoto's, risk can be reduced with adequate dietary intake of selenium, and the prevalence is lower than most think. I'm quite passionate, as you may have sort of pieced together, about giving people competent advice as it pertains to really their healthcare in general. my main area is gut health. And I've observed over the years such a connection between gut health and thyroid health that thyroid health has become one of my other chief areas of focus and concern. And concern is a good word to use because a lot of my interest has grown out of the concern that patients have who come into our clinic. They're oftentimes scared of their Hashimoto's. They're trying to hit these unrealistic and unnecessary targets with their TPO antibodies. They're overly avoiding food, including gluten. They're on a hormone that they may not need, and in some cases actually having worsening of things like fatigue and insomnia because they're over-medicated. And unfortunately, it seems that there are all these things that can be a problem, right? Your autoimmunity, gluten, a need for hormone, but they're all looked at in these sort of dire, binary, black and white perspectives. And people aren't given the prevalence data and the ability to make a personalized decision. Not everyone needs hormone. Not everyone needs to aggressively target their antibodies. Not everyone needs to avoid gluten. And so if we can personalize the recommendations to you, you now, in theory anyway, can have the most health with the least fuss. And that's really what I hope comes through with the review of some of these research studies. Okay, guys, well, hopefully that helps, and I will talk to you next time.